Good evening and a very warm welcome to every doctor who have joined today's webinar. I am Neetu Abraham, Community Manager at MediSage e-learning, a platform made by the doctors for the doctors, created to foster continuous knowledge sharing and meaningful learning and professional collaboration. This entire webinar is co-powered by Sage AI, which is an AI tool especially created for doctors. On behalf of MediSage, I am delighted to welcome you all to Sexual Health discussing on the topic erectile dysfunction. With this, I would like to hand over the session to Dr. Shama Sultana for further proceedings. Over to you, ma'am.
Thank you, Neetu. Good evening, everyone. On behalf of SexMed Connect, I warmly welcome all of you to today's session of Sexual Health Ki Pathshala episode 6 on erectile dysfunction. We are delighted to have such an enthusiastic gathering for an important yet often under-discussed topic, erectile dysfunction. This condition not only affects physical health but also had a deep psychological and relational impacts. Through this session, we aim to break myths, encourage open conversations, and provide evidence-based insights of better patient care. We are honored to have with us esteemed faculty Dr. Ala Satyanarayan Reddy sir, and their expertise and experience will undoubtedly enrich us with today's discussion. I would also like to acknowledge the efforts of organizing team, Dr. Neeraj Yadav sir, President, Dr. Apurva Datta sir, Vice President, and Dr. Shama Sultana, Secretary, and Dr. Naisargi, Joint Secretary. And I encourage all the participants to actively engage and ask questions and make the most of this learning. And before entering into the session, I would like to tell a few points on SexMed Connect. It's a dedicated sexual health forum for obstetric and gynecologists, and sexual health remains an integral yet often under-discussed component of overall well-being. Through this academic platform, we aim to create a safe, professional, and collaborative space where clinicians can learn, discuss, and share knowledge on various aspects of sexual health. SexMed Connect is designed to enhance patient care, encourage networking and collaboration with like-minded professionals, promote continuous learning through case discussions, academic updates, and shared experiences. Whether through our WhatsApp academic discussions or our educational content on Instagram, YouTube, Facebook, we strive to keep you informed, connected, and empowered. So let us come together to bridge gaps in sexual health awareness and deliver better, compassionate, and holistic care to our patients. So without any delay, let's go into the session. I invite my co-moderator, Dr. Gautam Sonavani sir, to introduce our expert faculty, Dr. Ala Satyanarayan Reddy sir. Over to Gautam.
Gautam, 1 minute. Hi all delegates. Thank you for joining, and we will have a exclusive 30-minute question-answer session after sir finish his talk. So please take advantage of that session. You can post your whatever query related to this topic in the question chat box on your screen, or you can send your query to any of us on our WhatsApp. We will try to solve your queries from the sir. Thank you. Gautam?
Thank you, Dr. Shama, for the kind introduction. Now, I'd like to introduce Dr. Ala Satyanarayan Reddy sir. It's my honor and privilege to introduce to you Dr. Ala sir. Sir is MD, DGO, MSc Psychology, MHSC, FI, CMCH, FCS, EPI, FECSM, and PhD. After 30 years of OBGYN practice and completing fellowship in European College of Sexual Medicine, sir is doing dedicated sexual medicine practice. Sir is retired professor OBGY from Vinayaka Mission University, professor of reproductive sexual health, Indian Institute of Public Health. Sir was consultant of sexual medicine at Apollo Fertility, Hyderabad. Am I audible?
Yes. Go ahead.
So, since last 14 years, sir is into exclusive practice of sexual medicine at Leo Institute of Sexual Medicine in Hyderabad. Sir was executive committee member of Council of Society, Secretary of Education and Parenthood, Indian International. Now he is vice president of governing council of newly established Indian College of Sexual Medicine. Also, Sir has presented around 50 research papers and contributed in 17 chapters of books in OBGY as well as sexual medicine. Like the books are Handbook of Sexual Medicine, Sex Therapy, A Chemical Guide, Sexual Facts in Medicine Disease. Sir was awarded PhD in sexual health and has worked on the sexual health. PhD was awarded to him on the work of pornography induced erectile dysfunction. Sir is recipient of Best Doctor Award for 6 times, and also Sir has received gold plaque from Chief Minister of Andhra Pradesh. And in Sir's special interest is male factor infertility and sex therapy. Over to you, sir.
Thank you, Dr. Gautam, for a nice introduction. Now, the topic for today's discussion is erectile dysfunction, especially in gynecologist perspective. First, we will complete the topic of sexual medicine, the topic of erectile dysfunction, followed by the things that are necessary are for gynecologists specially. So we divide it into two parts. Yes, sir. So premature ejaculation is the commonest sexual dysfunction in men. But erectile dysfunction is the commonest presentation of a sexual problem in clinical practice. For a sexologist, more than 50% of the cases are because of erectile dysfunction only. Because it leads to failure of sex act. It is a challenge to his manhood. A famous quote of Leo Tolstoy, but it's not a quote of Leo Tolstoy, but it is ascribed to him that a man survives anything, but the tragedy is and will be always the tragedy in the bedroom. 1 minute, sir. 1 minute. Now we will discuss the topic. Every man experiences erection failures at least a few times in his lifetime. Every isolated erectile failure should not be branded as or labeled as erectile dysfunction. So we will discuss the topic as definition, physiology of erection, prevalence of erectile dysfunction, what are the causes of erectile dysfunction, how to examine a patient when he comes for erectile dysfunction, what are the investigations to be done, how to make a diagnosis, and how to manage the case. In addition to this one, what is the response for the woman, or from the woman's perspective, we'll see erectile dysfunction. On a gynecologist perspective, we'll see the erectile dysfunction. Now, DSM One minute, sir. I am not able to.
So you need any assistance?
No need. No, because yes, sir. Now I am able to. Because the thumbnails is obstructing the view. Now the DSM-5, that is Diagnostic and Statistical Manual of American Psychiatric Association, in his chapter 5, they called it erectile disorder, not erectile dysfunction. And the code name is 302.72 F52.21. That is, erectile dysfunction is persistent or recurrent inability to achieve or maintain erection or significant decrease in rigidity during partner sexual activity on at least 75% of the occasions, lasting for at least 6 months and causing significant distress. So every erection failure, that is, every erection failure, isolated erection failure, should not be branded as erectile dysfunction or erectile disorder. It should be persistent and recurrent and there should be loss of, there need not be, he not able to achieve erection or not able to maintain erection till completion of the sexual activity. And it is during partnered sexual activity only. Good number of the patients come with the complaint that I am not having good erection at masturbation. No, it is only during partner sexual activity, then only you should call it erectile dysfunction. It should be happening in 75% of the instances of the sex. And it should last for 6 months. And it should cause significant distress to the man, not to the woman, not to the wife. So there are so many ifs and buts are there. So every sexual dysfunction, suppose an unmarried boy went to his, has taken his girlfriend and he is not able to have erection. It is not an erectile dysfunction. It can be called an erectile failure. So now you can understand why there will be so much of disparity in the causative factors or in the etiological factors or prevalence of disease. Some people, if they take as one episode of failure into consideration, then there will be this many number of people. If they consider all of it into all of these criteria, there will be this many number of erectile dysfunctions only. There are some subtypes called lifelong. It can be lifelong, or it can be acquired after some years of normal erectile function. It can be generalized in every situation, or it can be situational, occurs only with certain types of stimulation, that is, with hand, with mouth, with anus, or with vagina. Or in some situations, that is, he is able to do sex in particular place or in particular time of the day, or with a different person, with a partner. He may be able to do with wife, not able to do with his, not able to do with his extramarital girlfriend, or he able to do with a prostitute, not able to do with his girl, with his wife. So all of these things has to be, their subtypes or specifiers are there. Now, how erection happens? This is the structure of the penis. The penis is having 3 rods, a pair of corpora cavernosa and a single corpora spongiosa. The corpora spongiosa becomes bulky, hood-like in the front to make the glans penis. And the penis, half of it is only seen outside, the other half is the root of the penis. The root of the penis is in the superficial perineal pouch. Everybody knows it. Superficial perineal pouch contains all of these organs. That is, this portion is seen outside, this portion is inside. The root of the penis is attached to the pubic and ischial rami. This is superficial perineal pouch. A cut section shows 2 corpora cavernosa and a corpora spongiosa which carries urethra. There is a blood supply and nerve supply. Now, it is supplied by vessels. The vessel is pudendal and then cavernosal vessel. The cavernosal vessels goes through the corpora cavernosa. Now you can see it, there is a cavernosal vessel. Then, this is the cavernosal vessel. This is the cavern, in the normal state. In the normal state, the penis is having arterial supply. At the same time, it is having a venous drainage also. The corpora cavernosa is just like a honeycomb. The cells of the honeycomb are called sinusoids. The sinusoids are supplied with blood by the terminal arteriole. It is drained by a venule. And the corpora cavernosa, it is always surrounded by a muscular coat. The muscular coat contains nerve endings. So the corpora cavernosa is surrounded by a thick tunica albuginea. Anywhere, tunica albuginea is a tough membrane. In the normal state, the smooth muscle surrounding the sinusoid is always in a constricted state, so that a minimal amount of blood flow is there, and inflow by the artery, outflow by the vein is there, minimal amount only. Only during erection, what happens at the time of erection? At the time of erection, things will happen, things will change. The erection process sets in with a mental stimulus that is called fantasy, or a physical stimulus from the senses of touch, from the senses of sight. Erection is a parasympathetic phenomenon. Ejaculation is a sympathetic phenomenon. For the newcomers, I repeat, erection is a parasympathetic phenomenon. Ejaculation is a sympathetic phenomenon. In the natural flaccid state of the penis, the muscular coat surrounding here, the muscular coat surrounding the sinusoid will be always in a contracted state. With a parasympathetic stimulation, the cavernosal vessels artery becomes wider. The terminal arteriole called helicine artery becomes dilated by 3 to 4 times so that the blood flow becomes more. This is flaccid state, the erectile state. So blood enters. Once the blood enters the sinusoid, the veins are compressed. There is no outflow for the blood. When there is no outflow for the blood, there is always accumulation of the blood. That results in bulkiness of the penis. The next one, but bulkiness is not enough. The bulkiness is called tumescence only. That is the first step of erection. In the second step, further increase in the blood flow with lesser amount of outflow by means of closure of the veins. That results in more amount of blood pumping against the tough tunica albuginea that produces rigidity. So tumescence with rigidity is called erection. This is the process of erection. Now we go, how common is erectile dysfunction? Erectile dysfunction is so common. Erectile dysfunction, this is the largest study done in the world, MMA study, done about 35 years ago. Nobody can surpass the findings of this one. Generally speaking, 50% of the people above 40 years of age, I repeat, 50% of the people above 40 years of age are having some amount of erection failure. 10% absolute, moderate amount some percent, minimal amount some percent. But only 50% of the people don't have any erection problem. To tell you the other way, in an MMA study, at 40 years of age, 10% of the people will be having severe erection failure or complete erection failure, absolute erection failure, which becomes more gradually with age. At 70 years of age, the complete erection failure will be 20%. That is, at 70 years of age, 20% of the people will be having absolute erection failure. But there are a good number of the people who will be having minimal and moderate amount of erection failures also. If you combine minimal, moderate, and complete erection failures, as a rule of thumb, I am telling as a rule of thumb, just for people to recollect, 40% of people at 40 years of age, 50% of the people at 50 years of age, 60% of the people at 60 years of age, 70% of the people at 70 years of age, just to make everybody to recollect, will be having some amount of erection failure. But absolute erection failure will be seen there in 10% of the people at 40 years of age and 20% of the people at 70 years of age. This is the authoritative figures. This is as per the definition. Now, here there is an interesting thing regarding age group. Gynecologists are concerned with erectile dysfunction of men less than 40 years of age only. They are not concerned with elderly men. They may do practice, but they are not concerned. Most of their patients are coming from problem will be there only in 40 years of age. But here it is so interesting to see that men below 24 years of age are having 18%. Between 25 to 40 years of age, it is only 13%. The reason is not that people are having more difficulty or less difficulty after 25 years of age. Yet before that one, they are inexperienced. Even for a minimal problem, they'll be more worried about. That is the reason. Now, what are the etiological factors? Now we come, a little extra thing we wanted to tell. In elderly men, there is erection failure. Is it a part of aging process or is it a disease? When more than 50% of the people are having the same problem, can we call it a disease? It can be an aging process also. Nobody knows. Suppose somebody is having less mobility After 50 years of age, they don't care for it. But somebody is having small amount of erection failure at 50 years of age, they don't accept that it is aging process. That is the reason more number of people are coming now in the early age group people for a treatment of erectile dysfunction. Now, the etiological factors, erectile dysfunction can be an organic disease or a psychogenic disease or a psychogenic problem. It can be an organic disease or it can be a psychogenic problem. I don't say psychogenic disease. Now, the risk factors of organic ED only I am telling now. So people, when they read the textbook, they will be quite worried about one book gives this many number of people, another book gives only less number of people. So they don't specify. All the reasons are applying only to the organic erectile dysfunction. Then age, lifestyle, environment, metabolic disease, other medical diseases, neurogenic, hormonal, psychiatric disease, iatrogenic, and local factors. The same thing in a different form. Now, we just now talked about age. Now we go for the lifestyle. A sedentary lifestyle predisposes a man to have erectile dysfunction. A simple physical exercise by itself, without any other treatment for ED, relieves ED in 30% of the people. Whereas good sleep, lack of good sleep causes erection failures, stress causes erection failures. Then we go for the smoking. That is, smokers are 1.5 times more likely to have ED. Nicotine, everybody knows nicotine is a vasoconstrictor. So it produces erectile dysfunction. Then alcohol less than 120 ml of whiskey, there is no deleterious effect on the sexual or erection process. In fact, it will be beneficial. It relaxes the man, removes his inhibitions, and he participates and enjoys sex fully. The woman may not enjoy the alcohol smell of the man, but the man definitely enjoys. In good number of instances, a man who has taken a peg of whiskey will be able to participate in sex very vigorously, and some people use it as a treatment for premature ejaculation also. Then environment, the gynecologists know, it is the steroid hormones are affected by pesticides, plastics, and chemicals. No need of telling it much more. Now we come for the metabolic disease or metabolic syndrome. The metabolic syndrome, now in addition to that one, a weed or marijuana increases the performance. Other recreational drugs may be deleterious or may be improvement of the sex also. There is a metabolic disease. Obesity is an independent risk factor for ED, not associated with other metabolic syndromes. Obesity by itself is a risk factor for ED. The relative risk of ED in obese men is 1.5 to 3 times more. Whereas hypertension is a comorbid factor of ED. Half of the elderly men with ED have hypertension, whereas 1/3 of the elderly men with hypertension have ED. Dyslipidemia is a risk factor for erectile dysfunction. Diabetes is the leading cause of erectile dysfunction. The risk of erectile dysfunction in men with diabetes is 3 to 4 times more than general population. Men with diabetes mellitus have an early onset of ED. This is more worrying. The duration of the diabetes, the severity of the diabetes, the control of the diabetes decide the prevalence of ED and the severity of ED. Practically to tell, every man with diabetes will have erection failures in due course of time. If they are a control of diabetes, it may take 20 years for the erection failure to set in. If it is not controlled, it may take only 5 years to establish erectile dysfunction. That much of importance is there for diabetes. Once erectile dysfunction is established in diabetes, it is a permanent thing. It is almost lifelong. You can manage that one, but definitely he will be having erection failure. Erection failure won't mean that always needing a tablet. Erectile failure, erectile dysfunction in diabetes is usually resistant to medical treatment. Now we go for the endothelial dysfunction, vasculogenic ED, and coronary artery disease. These people has to realize the importance of coronary artery disease and erectile dysfunction. Endothelial damage is the key factor of ED and coronary artery disease. Erection is a vascular phenomenon. Endothelium is the lining of the inner side of the blood vessels. Endothelium releases nitric oxide. Nitric oxide is necessary for erection. Damage to the endothelium is called endothelial dysfunction. Endothelial dysfunction leads to atherosclerosis. Endothelial dysfunction results in less production of nitric oxide. So atherosclerosis and less production of nitric oxide results in ED. Endothelial dysfunction, atherosclerosis, erectile dysfunction, coronary artery disease, cerebrovascular disease are the continuation of the same disease process. I repeat, endothelial dysfunction, atherosclerosis, erectile dysfunction, coronary artery disease, and cerebrovascular artery disease are the continuation of the same disease process. So, so the obvious implication is erectile dysfunction precedes coronary artery disease by 5 years. The reason is the cavernosal artery is small in size, whereas coronary artery disease is 5 times more than the size of the coronary artery. That is the reason why erectile dysfunction comes earlier than the coronary artery disease. So, men with erectile dysfunction are 1.5 times more prone to have coronary artery disease than non-ED men. So, it is considered that erectile dysfunction is a reliable predictor of coronary artery disease. So, a man with vascular ED, I repeat the word, a man with not ED, a man with vascular ED should be investigated for coronary artery disease. A man with psychogenic ED, no need. A man with neurology, no need. But a man with vasculogenic ED only should be considered for investigation for coronary artery disease. Normally, if one of you listen to the briefing by the representatives, whether it's a Viagra or some other company, they go on telling everything that every patient with ED should be investigated with coronary artery disease. No, a patient with vascular ED only has to be investigated for coronary vascular disease. So the other medical diseases, so the relative risk of erectile dysfunction is in diabetes, it is between 3 to 4 times, whereas in peripheral vascular disease 2.5 times. Cardiac patients, hypertension and hyperlipidemia, it is between 1.7 and 1.8 times. Now, out of every 100 cases of erectile dysfunction, 40% is accounted by, this is only for organic ED, not psychogenic. So 40% is accounted by the vascular ED and 30% by diabetes, 10% by neurological disease, 10% or more than 10% today by drug-induced. Endocrine diseases account only for 5%. People are worried about endocrines and testosterone. No, in a big sample of erectile dysfunction, only 5 or 6% of the people will have testosterone deficiency. It is the cause, but testosterone deficiency is not the sole cause. Majority of the cause is only vascular. Whereas depression and anxiety will be having 1/3 of the patients with depression, or diabetes mellitus, 30% of the people will have erectile dysfunction. With angina, 30% of the people will be having erectile dysfunction. Now, the other diseases that cause sexual erectile dysfunction are COPD, chronic obstructive pulmonary disease, because of less amount of oxygenation to whole of the body, including cavernosal tissues. A sleep apnea is an independent risk factor. Sleep apnea, good number of people will be using mask in the middle of the night. Or a prostatic infection that results in lower urinary tract symptoms, LUTS it is called, is an independent risk factor for the causation of erectile dysfunction. But I'm making it lesser because this comes at a later age group. So gynecologists are more worried about the younger age group people. A neurological disease, the commonest cause is autonomic neuropathy. or a peripheral neuropathy that affects the sensations of the glans penis can result in less amount of sensations. If at all if the somatic nerve is involved in peripheral neuropathy, then the ejaculation process is not happening. Multiple sclerosis, a psychiatric diseases, depression, schizophrenia, anxiety neurosis. In schizophrenia, half of the people will be having erectile dysfunction. In depression, 30% of the people will be having. Anxiety neurosis depends upon. In some people, it can make the erection more also. But majority of the people will be having less erections. At least 1/4 of the people with anxiety neurosis may be having occasional erection failure, not defined erectile dysfunction, or a local destruction of the perineal tissue by whatever means. Suppose a long distance cycle rider, when he is pressing his perineum against the hard seat, the nerves may be compressed, the blood supply may be compromised, leading to the destruction of the cavernosa tissue. Priapism is one of the reasons. Now we go for the iatrogenic. Every drug is implicated in the iatrogenic process, but everybody will feel that every drug is the causes erectile dysfunction. No, it is the disease for which we are using the drug is the causative factor of erectile dysfunction, not the drug treated. Suppose somebody is having psychiatry, somebody is schizophrenia. Schizophrenia is the cause for erectile dysfunction, but the drugs used for schizophrenia may be aggravating the factor, but it is not the sole factor. Now, the common drugs used are beta blockers are definitely, because beta blockers definitely, that is propranolol, not in ordinary doses, methyl dopa, clonidine, digoxin, thiazide derivatives. Good number of the people are using thiazide, that is gas hydrochlorothiazide. H is added. Spironolactone, everybody knows it, that is anti-androgen. And the gastrointestinal drugs, cimetidine, metoclopramide, and doperidone, these are also same effect in the metabolism of hormones. Phenytoin and carbamazepine are the definite causative factors. The next one is finasteride and dutasteride. These two drugs are commonly used. The finasteride and dutasteride used for hair growth. All of the people who got hair transplantation, then they will get finasteride tablet or dutasteride tablet. Or people with prostatic malignancy or prostatic hypertrophy, they will be given finasteride and dutasteride. These things are, dutasteride is definitely going to make anybody have less amount of dihydrotestosterone. Then psychiatric drugs. All the psychiatric drugs will be having one sexual side effect or other. The operations of the penis for cancer of the prostate, colon and bladder, especially cancer of the prostate, colon and bladder, whole of the pelvis is accentuated. The nerve supply and blood supply from the penis comes from back to the front. So even if you do nerve sparing one also, when you accentuate whole of the pelvis, the blood supply to the penis is cut off. The nerve supply to the penis is cut off. Suppose somebody underwent a colonic surgery at a younger age group, they will be definitely having erectile dysfunction. Radiation of the pelvis destroys the cavernosal tissues, destroys the testis, causing less amount of testosterone. Chemotherapy drugs, it kills every cell. Now, we come for the psychological causes of erectile dysfunction. Now, before going this one, a psychiatric disease we should elaborate a little. That is, anxiety neurosis leads to erectile dysfunction, whereas 1/3 of the men with depression have erectile dysfunction. The prevalence of erectile dysfunction in depression is 1.5 times more than the general population, and the incidence of depression in erectile dysfunction is 3 times more. So the relationship between erectile dysfunction and depression is bidirectional. Depression leads to erectile dysfunction, and erectile dysfunction leads to depression. So it is a bi-way process. So to tell that a drug is causing erectile dysfunction, every drug, whatever new drug they use, they blame the drug, not themselves. So it is a common fancy of the patients to blame a drug for every disease. To tell that a drug is causing erectile dysfunction, there should be a temporal correlation, that is the time of the usage of the drug, the onset of the ED, and the improvement of erection after discontinuation of the drug. There should be these three criteria, that is the usage of the drug, the onset of the erectile dysfunction, and after discontinuation of the drug, there should be improvement in erectile function. When these three are there, then only you should call it an iatrogenic. Otherwise, it is not iatrogenic. It is there because of the fear of the patient that they are using a drug and that is causing. Now, we go for the psychological factors. If you recollect some time ago in the first module, I have talked on psychotherapy for sexual dysfunctions. There, I described in detail what are the psychological factors that cause sexual dysfunctions in general. But here, because some new people might have joined, I make it far lesser. In a few minutes time, I complete. So, psychological causes of ED and psychological treatments of sexual dysfunctions were discussed by me in this group of doctors. Briefly, some remote factors predispose a person to have ED. They are developmental factors, that is negative family values towards sexuality, parental marital discord. If the mother and father are always quarreling, then the boy will be having sexual problem. A traumatic childhood sexual experiences and homosexuality, gender identity disorder, poor self-esteem, that is affective disorders, anxiety, guilt about masturbation, sex, hypochondriac disease, fear of pregnancy, fear of sexually transmitted diseases, and cognitive, that is the recognition of something, a sexual ignorance, a sexual myth, and sexual misinformation, a sexual misinformation by friends, by facts, and now by pornography. More so in the recent times by the people who are talking on YouTube channels. That is, short videos of YouTube is causing more damage to the man's sexual function than anything else today. So they spread so much they have so much amount of misinformation about the causation, about the treatment schedules. So that is causing more sexual dysfunction than anything else today. This is remote causes. Some immediate factors trigger erectile dysfunction in a vulnerable individual, not in every individual. Suppose an individual is vulnerable by means of his development or by means of his ideas, then he is susceptible for having erectile dysfunction or any sexual problem. He is vulnerable. Once they are vulnerable, even a small factor of immediate factor can be a reason for erectile dysfunction or sexual dysfunction. There are three here: a performance anxiety, spectatoring, and loss of abandonment. A performance anxiety is the fear of failure in the present sexual act based on the failure in the previous sexual acts. I repeat, a performance failure is the fear of failure in the present sex act basing on the failure in the previous sex act. He doubts his erectile capacity, approaches the woman with a failed mind, fears the consequences of his erection failure. This is called performance anxiety. At sex, a man has to abandon himself to the lust. But when somebody is having an erection failure earlier, he can't abandon his lust. He can't abandon whole of his mind to the sexual pleasure. He will be concentrating on the something else other than one. It is just like a man who has gone to to see the god. His mind is always concentrated on the chapels left outside. In the same way, when a man is doing sex, his mind is not concentrated on the pleasures of sex. He is concentrated upon what are the consequences of if he won't do good. So these are the psychological causes of sex failure. Then comes the relationship factors. This one I dealt with, so I am not dealing with it in detail. A relationship factors is poor communication between the partners, poor relationship between the partners. Poor communication, even though there is a good relationship, if there is no communication between the partners, what I want, what you want, without particularly in the case of woman, the woman wants particular way of doing stimulation to her, but she won't let the husband know what is it. He don't know. That is the more commonest cause of not erectile dysfunction, less satisfactory sexual intercourse. And the people may be having a divergent sexual preferences. He wants a blowjob, she is elected. She wants romance, he wants sex only. There is a difference in the type of the sexual activity, the type of the sexual activity, the frequency of the sexual activity. Both of the husband and wife don't have the commonality. So the difference in the sexual values of the couples, everybody comes from different strata. A woman will be born with a different value system of the sex in their family. The man will be having a different value system. When the value systems of the families cross, there will be definitely sexual problems. So attractiveness or distrust and hostility towards the partner. Attractiveness of the woman, of his preference, even though he is so much attractive, some people may like a boy, some people may like a heroine, like some people may like the hero's sister, some people may like the vamp. So the preference of everybody will be different. Some people may like elderly woman. So these are the relationship factors. Then the last one, which is a suspected infidelity of the wife. This is quite common today, particularly in the younger generation people employed. Now, we go, how frequent is organic, how frequent is psychogenic erectile dysfunction in clinical practice? I am talking of clinical practice now. In personal clinical practice, I see most of them my cases are referral cases only, not direct cases. Good number of people come to me after they got treatment somewhere else, or they are referred by colleagues, sexologists, or by urologists, like that. So in young men with premarital sex, in young men at premarital sex, are honeymoon impotence, honeymoon erection failures. 90% are psychogenic, only 10% are organic. In young men, in premarital sexual experiences, or new sexual experience as that honeymoon, or in the first night. In young adults, less than 40 years of age, 1/4 are organic disease, 3/4 are psychogenic origin only. In elderly men, 3/4 are of organic origin, 1/4 are psychogenic origin. This is not exact figures I am talking. This is general to give an idea that what is in clinical practice, how much percentage of people will be having a psychogenic. Suppose next, I wanted to highlight one thing. Somebody is having an organic disease in sexuality as a cause for their sexual problem. It won't mean that they don't have psychogenic dysfunction. Everybody who is having an organic disease, half of the people will be having a psychological disturbance also, which is a result of the sex dysfunction. So we have to treat a psychogenic problem, which is the cause of the sexual problem, which is the result of sexual problem. It disappears on its own without any treatment. We have to give counsel only the patient. Now this completes the etiological factors. 1 minute, sir. I have to check my time. I have taken good lot of time, sir. Now we go for the clinical examination evaluation is history taking. What is the problem of ED? How much duration is there? Is it gradual in onset or acute in onset? If acute, is there any precipitating factor just before the problem? What is the frequency of the sex before the problem and after the problem? Are you having nocturnal penile pubescence or not? Are you able to masturbate freely? Or do you have erection failure earlier also? You are not having erection or losing erection? Or in how much percentage of the instances you are losing erection? Are there any other techniques which you are resorting to make you harder? Any other associated diseases or sexual problems like lack of desire, no ejaculation or quick ejaculation, or any sexual dysfunctions in your wife? And then you have to ask, what is the response of your partner? What consequences you encounter? Then you have to ask for a lifestyle, alcohol, smoking, relationship, sexual history. What is sexual history before marriage? What is sexual history? Premarital sexual history, marital sexual history. What is the frequency of the marital sexual history? Is he having extramarital sexual partner or not? What are the medical diseases he is having? What are the sexual problems and history? Now, at examination, look for the man. Clinical examination, look for the secondary sexual characters. Look for a Klinefelter syndrome. Look for gynecomastia. It is self-explanatory, no need of explaining to a gynecologist. Look for the BMI, obesity, BP. Is there an excessive amount of suprapubic fat? Then the length of the flaccid penis, deviation of the flaccid penis, and curvature of the penis. Any stigmata of the sexually transmitted diseases? Phimosis. Whether the urethral opening is at the tip or hypospadias is there. Are there any plaques in the penis? Then see for a varicocele, see for a hernia, and feel for the testis, whether the testis is normal size or not. Then a digital rectal examination is to be done to rule out a prostatic disease. Then there are two, cremastic reflex and bulbospongious reflex, but these are for somebody specialist. So after you examine the patient, then there is a scale of erectile dysfunction that is called IIEF scale 5. It is having 5 factors and 5 marks for each one. 5 marks for each one, 1, 2, 3, 4, 5. Total 25 marks are there. A people who is having between 20 and 21 and 25 are normal erections. Blindly to say 20 to 25 normal, 15 to 20 mild erectile dysfunction, and 10 to 15 moderate, less than 10 severe. It is only guideline. There may be 1 plus or minus. That is, less than 10 is severe, between 10 and 15 it is moderate, and then between 15 and then 16 and then 20 it is mild, above 20 it is normal. Now, what are the investigations to be done? You need not do many investigations for every case of erectile dysfunction. A basic hemogram is to be done, urine examination routine, fasting blood sugar, lipid profile, and total testosterone. Only these things are necessary. More than that, it is not necessary. But people pester us to do more number of investigations. So we do investigation not for the sake of the knowledge, for the sake of the patient satisfaction only. So the additional tests that to be indicated, suppose there is a hormone disturbance, low testosterone in young man, then you have to do TSH, FSH, LH, prolactin, estradiol in a bulky man and free testosterone. Penile bronchial index, penile Doppler with intracameral injection of vasoactive drugs. This is a specialized test that is done. A vasoactive drug like a papaverine is injected into the corpora cavernosa, and they see arterial blood supply, that is peak systolic velocity, end diastolic velocity, just like in any other case. And rescue index will be done. If a rescue index is less than 8, then it is problematic. A systolic velocity of a papaverine injection less than 25 is arteriogenic. A persistent end diastolic velocity more than 5 centimeters per second consistently is venogenic. So these are special tests that to be done, not for a general practitioner. A nerve function study is most of the times is a useless thing, but we do for the sake of the patient. That is sensory evoked potential and somatosensory evoked potential, or very simple thing. Very simple. Whatever the diabetologists do with a Doppler, you can do it. Cardiac evaluation is done by a treadmill test. Then how to differentiate between organic and psychogenic origin? The difference is organic is old, psychogenic usually in younger people. In organic is always a gradual deterioration, whereas in psychogenic it is acute in onset. It is global. In every situation, organic factor will be there. Whereas in psychogenic, in some situations he will be good, in some situations he is bad. It is always a progressively deteriorating factor. Whereas in psychogenic it is intermittent. That is, 2 years ago he had erection failure, relieved spontaneously. Now he is having erectile failure. In between these 2 years he is normal. Whereas desire is normal in an organic disease, whereas desire is decreased along with the psychogenic factor. There can be associated medical disease or associated psychological disease in a psychogenic factor. NPT is absent or lesser, whereas in psychogenic NPT is always present. Now, what is the treatment done to be done? Lifestyle changes. Lifestyle changes. Treat the causative medical diseases. Whatever disease he is having, treat. Then hormonal supplementation if there is a testosterone deficiency. Then pharmacotherapy, the main line of pharmacotherapy is PDE5 inhibitors. The next ones are second line drugs, second line treatment schedules. Now, somebody is having low amount of testosterone in a young man. When somebody is having low testosterone, total testosterone, then go for FSH, LH, prolactin, and estradiol also. Then, if somebody wanted to have children with a low testosterone, don't give testosterone supplementation. Even if he is having a testosterone lesser, don't give testosterone. This is fundamental. So I highlighted, wants to have children, no testosterone supplementation is to be given. Instead, you can treat it by means of a clomiphene citrate if the FSH is high. If the FSH is, if the LH is low, give HCG. Then, if the moles per liter is around 30 times more is nanograms per deciliter. That is 240 nanograms per deciliter. With less amount, he will have erectile dysfunction. If it is less than 360 nanograms per deciliter, he will be in a depressive mode. If it is less than 450, he will be having loss of libido. So loss of libido is the first one to go. Then he goes into depressive mode. And the last one is ED. Now, how to treat it? Oral testosterone capsules are there, 40 to 120 milligrams daily, but it has taken with a full meal. It is not practical. So, injection testosterone, a natural testosterone, 100 milligrams once in a week. That's the aquavarine injection we routinely use. Testosterone esters 250 milligrams once in 2 to 3 weeks. Or testosterone esters in a depot form, 1000 milligrams once in 3 months. And much more nicer thing is gel is there, testosterone gel, which is native drug, that is 5 milligrams daily to be applied in the morning daily. These are the testosterone supplementations. Then to make a little change, the treatment, first line treatment for erectile dysfunction is we are going to do with sildenafil or PDE5 inhibitors. Now here, there is a peahen, there is a peacock. The peacock is not having erection. The peacock is asking the vet to give him a Viagra. Immediately after getting a Viagra, he is having peacock is rising, just to make it funny. Now, in a normal situation, nitric oxide is released from the nerve cells and the endothelial cells. The base for nitric oxide is L-arginine. So it converts, nitric oxide makes guanyl cyclase more. It converts guanyl triphosphate into CGMP, ganosin monophosphate. Ganosin monophosphate is vasodilator that produces erection. But ganosin monophosphate, CGMP, is short-lived. Then it is destroyed by PDE5 inhibitors once more to GMP. So this is PDE5 inhibitor. Then how PDE5 inhibitor works? That is, the ganosin cyclase converts ganosin monophosphate into cyclic ganosin monophosphate. It is destroyed by PDE5 enzyme. And when you give PDE5 inhibitor, the cyclic GMP is becoming more. So more cyclic GMP, more erection. This is independent of a desire. Now, what are the indications for PDE5 inhibitors? Any organic ED, this is a first level indication. Even for psychogenic ED, it is the first line treatment only. And situational ED, when there is an ED plus PE also, this is the treatment. PE alone, it can be a treatment also for a good number of the people, not for everybody. It is not a treatment, but it works for some people. Whereas for psychogenic ED, always make a point. For psychogenic ED, everybody thinks that the psychotherapy is the treatment. No. If somebody is having erectile psychogenic ED, if you give Viagra, he will be having good erection and the psychological factor is gone. For in a woman, it is the only indication is antidepressant induced female arousal disorder and infertility cases. Whereas contraindications are an absolute concomitant use of nitrates, severe hypotension, recent MI, recent stroke, severe cardiac inactivity. Relative is retinitis pigmentosa. Anyone with an exercise tolerance of 5-6 METs on treadmill test can use PDE5 inhibitor safely. PDE5 inhibitor won't cause coronary artery disease. It can be used even after treatment for a coronary artery disease, even somebody is having, provided he is able to do treadmill test to a tune of 5 to 6 METs. Then the drugs used are sildenafil citrate, 25, 50, 100 milligrams to be taken before food on a fat-free meal 1 hour before sex. The action starts in 30 minutes, reaches maximum in 70 minutes, and effect lasts for 8 hours. Vardanafil is also same. Tadalafil is another long-term drug. That is 5, 10, 20 milligram. The action starts in 30 minutes, reaches maximum in 2 to 3 hours. And the action half-life is 18 hours and the action lasts for 36 hours. So this is one night for night. This is for weekend. Yavanafil works much more faster in 30 minutes or 20 minutes, and the action starts in 30 minutes. Half-life is 6 hours. It lasts for whole of a night. Now, the side effects of these one are a good number of people will be having headache, flushing of the face. Dyspepsia is more common with sildenafil and tadalafil, and backache is more common with tadalafil. Color vision, visual disturbances in the form of blue spots in front of the eyes is common with sildenafil. Now we go for the second line treatment. The second line treatment for when the medicines won't work, then we go for the second line treatment. This is called vacuum erection device. Normally, during sexual activity, blood is pumped into the penis. But here, when the blood is not being pumped into the penis, we suck the blood into the penis. The sucking is done by means of a vacuum pump. Anybody can see this is a vacuum pump which people use. This is a vacuum pump. Vacuum erection device pump. Here they keep a penis inside and a switch will be here. A negative pressure will be created. Here there is a ring. The ring will fall over the base of the penis after the tumescence is there. But it is not erection. It is only after tumescence we can get it. But he'll be able to having a satisfactory intercourse. A negative pressure is created manually or by means of a mechanical device, and then immediately after he got an erection, a ring will be kept here. It falls automatically. This is vacuum erection device. The next one is injection, intracavernosal injection of vasoactive drugs. The common drugs used are pepaverin and alprostodil, are a combination of these two. Here, with an insulin syringe, just before intercourse, into one corpora cavernosa with a 5-needle insulin needle, the drug is injected. It produces good erection in 15 minutes of time. But the problem is, every time when he wanted to do sex, he has to take an injection. So, occasionally, suppose somebody is he had taken a more dose, then persistent erection is called priapism, which lasts more than 4 hours. This is a problem. This is a way to get an injection done. Now comes in the last stages, when nothing is working. This is implant is there. The implants are there is a penile implant is done. In good number of the cases of diabetes mellitus, which resulted in loss of whole of the tissue, there is no erectile tissue and there is no response for any of the drugs. Then you have to go for implant. The implants are of two varieties. One is a malleable implant. This is just like this. The malleable implant is kept inside the penis. The half of it is outside, half of it is in the base of the penis. Then when you wanted to do sex, he has to straighten the rod. It is a malleable one. And the size of the penis will be little lesser, 1 centimeter lesser than his original. The thickness is also little lesser. But even after ejaculation also, it will be straight. So you have to make it bent after your wife is satisfied. This is a semi-rigid implant. There is another implant called inflatable implant, which is having two cylinders. The two cylinders are connected to a bag of viscous fluid, and there is a switch here. The two cylinders are kept inside the penis, and there is a bag here. If you switch on this one, the switch is kept in the scrotal sac. Then the liquid from this one is pumped into the corpora cavernosa tissue, or it inflates the cylinders. It produces erection. When your job is completed, you have to switch it off. Both of these things, inflatable implant is much more costlier than semi-rigid implant. This is the one. Now, for the psychological interventions, last time I discussed in detail, the treatment is counseling, implicit model, cognitive behavior therapy, couple therapy, sex therapy, sensate focus, and special techniques for ED in sex therapy. These are the treatments. I'm not going to through it one. So this completes the first part of it. Now we come to the second part of it. That is to see erectile dysfunction from a gynecologist point of view. So whole of it applies to the gynecologist also, but there are some things which people has to know, gynecologist has to know. Now, that man is having erectile dysfunction, people are peeping through. It may be a wife, it may be a doctor. Now, this is just for a joke. My husband is 300% impotent. I'm not quite sure what you mean. Could you elaborate? Well, the first part you can imagine, but he also burned his tongue and broke his finger. Just for fun sake, I did it. Now, everybody sees a problem in their own angle only. A gynecologist sees a problem from infertility in gynecology only, not in male factor. In the same way, every problem will be the same, but it will be viewed by people in different perspectives. Just to give an example, 1 out of 8 men suffer from impotence. This is a good statement. Does it mean that 7 out of 8 men enjoys impotence? Anybody can argue. Or 7 out of 8 men don't have impotence. So the sex problem can be seen in different perspectives, by situations, necessity of the client, necessity of the partner. These things decide the treatment strategies to be adopted. Now, wife's perspective of the husband's sexual dysfunction. If you are not interested in wife's perspective, I skip these two. Wife's perspective of the husband's sexual dysfunctions. Now, if time permits, then I go for these two also.
Yes, sir. Yes, sir. You can go ahead. No, sir.
But because time has to permit. So I complete the gynecologist's perspective, then we go for the woman's perspective. So, in the gynecologist's perspective, male sexual dysfunctions causing diseases and sexual problems in women, female sexual dysfunctions causing male sexual dysfunctions, two-way. Male sexual dysfunction causing female sexual dysfunctions, female sexual dysfunctions causing male sexual dysfunctions. Gynecological diseases causing sexual dysfunctions in the male. Vaginismus causing male sexual dysfunctions. And menopause and andropause together. That is called couple pause. Then we go for unconsummated marriage and infertility and sexuality. So this way we go. If it may take around 15 more minutes. Am I permitted,
no problem, sir. You can. Yes, sir. Yes. Okay, sir. It's fine.
Now we go for the male sexual dysfunctions causing diseases and sexual problems in women. Causing diseases and sexual problems. HSDT, low sex desire in men, causes low desire. That is a pink color is for women. Low desire, rejection of the people, doubts about her attractiveness and about her femininity. Whereas erectile dysfunction can cause low sex desire in the woman, arousal problem in the woman, orgasm difficulty in the woman. Whereas the premature ejaculation causes low desire in the woman. Female arousal disorder is there. There is no arousal if she is finishing faster. Female orgasmic disorder is there. There is no satisfaction for the woman. So, male sexual dysfunction causing female sexual dysfunctions, whereas delayed ejaculation, retrograde ejaculation, and hypospadias in the man causes infertility. Delayed ejaculation, retrograde ejaculation, and hypospadias causes infertility. Then the next one is recurrent unexplained pelvic symptoms. Recurrent unexplained pelvic symptoms. One of the reasons for this one is male sexual dysfunction. This is idiopathic. Good number of people will be complaining recurrent unexplained pelvic symptoms. One of the reasons is male sexual dysfunction. How it happens? Now, how it happens? That is, That is, somebody is having a severe premature ejaculation, a man is having. The woman is excited. When she is having an orgasm, when the woman is excited, all the pelvis is filled with blood. That is, vasocongestion will be there inside the pelvis. And immediately after orgasm, the blood flow goes back into general circulation. That is, vasocongestion, the pelvis is relieved. When there is no orgasm and there is stimulation in the wife, then the vasocongestion is not relieved. But in due course of time, after half an hour or so, the vasocongestion is relieved so slowly. Normally, after orgasm, the vasocongestion will be like this. But when there is no orgasm, the vasocongestion will be slowly going down. So this is one of the reasons. This as a gynecologist I learned. In the place where I used to work, it is a Singareni employees, that is the minors. People used to drink and then they do sex very poorly. And then the woman used to complain of chronic low pelvic pain, low backache, discomfort in the lower tummy, sticky white tears continuously coming. There is no disease in that woman. And then I found out by means of trial and error only that the severe degree of sexual unsatisfaction causing pelvic congestion syndrome. Normally, pelvic congestion syndrome is a vascular phenomenon of structural, but here it is functional one. So pelvic congestion syndrome, one of the reasons is sexual dysfunction in the man. Now we go for the female sexual dysfunctions causing male sexual dysfunctions. That is a general to all female sexual dysfunctions is, suppose somebody is, the wife is not having arousal, then the man have reduced confidence. He feels that he is rejected by the wife. He feels he won't be active in sex. When somebody is not having desire in the woman, and he won't be responsive, he will be non-communicative, then he goes down, his sex interest goes down, less satisfaction. So any general sexual dysfunction in a woman will create these sort of male sexual dysfunctions. Whereas low sex desire in the woman cause low libido in the man, erectile dysfunction in the man, or it can cause delayed ejaculation also. Whereas female organic disorder, if a woman consistently tells that I am not having orgasm or satisfaction with you, then he will be putting pressure on himself, performance pressure to satisfy her. That causes him so much of sexual dysfunction in himself. The reason is she is not having orgasmic problem, she is not having orgasm. Then female infidelity, whether it is real or suspected, he feels betrayed, self-doubt about his capability when compared with other paraper, or he feels rejected and he develops performance anxiety to make it much more stronger so that she won't go out. He develops low desire, ED at sex. There is no erection, or it leads to masturbation. There is no erection failure at masturbation in this one. There is erection failure with the wife because real or suspected infidelity. Then menopause. In menopause, there is always decreased libido, fear of causing discomfort and pain. So the man feels that there is a decreased libido. Then he feels that she may be having discomfort, pain after menopause. Many men think that women after menopause, they don't like sex. In pregnancy, the man will be having a fear of abortion, causing harm to the fetus, and he thinks that she is not attractive. In a postpartum depression, competition with the child. This is so common it is. He competes. My wife is giving more importance to the child than me. So pelvic inflammatory disease, a chronic pelvic pain, dyspareunia, vulvodynia leads to reduced sexual frequency and negative sexual attitude and voluntary pee in the men. When the woman is suffering, he wanted to finish off it earlier. He may develop ED also. So pelvic inflammatory disease in the woman, a man cannot see the torture to the woman, and the woman will be interacting with the man less frequently. A prolapse repair surgery, a radical hysterectomy, artificial menopause, chemotherapy, radiation, all of these things lead to shortening of the vagina or stenosis of the vagina, leads to no lubrication and poor response. That is, all of these things, there are gynecological diseases causing sexual dysfunctions in the men. Now we go for the next one. Vaginismus causing male sexual dysfunction. Vaginismus is a dysfunction in the female, but it causes male sexual dysfunction. Vessel is a dysfunction. Normally, everybody thinks that is a problem of exclusively of the female, but there is a male contribution also to it. It leads to unconsummated marriage. 20 to 25% of the men whose wives have vaginismus develop ED. I repeat, 20 to 25% of the men whose wives have vaginismus develop ED. It is a secondary, situational. When he is not satisfied and when he thinks that his power is not enough to penetrate her, he feels it is a challenge, he loses erection. Then he is habituated to ejaculate over vulva very quickly. Failure to enter is a challenge to his sex power. It results in performance anxiety in the man. It leads to disappointment. And there is a fear of hurting the syndrome. It is a fear of hurting the woman. A nice guy syndrome. If people won't laugh at me. And vaginismus is more common in the woman whose husbands are soft-natured, whose husbands are tough-natured. Vaginismus will be lesser, but it is not foolproof, but it is an observation made by good number of people. So vaginismus causing male sexual dysfunctions. Now the menopause is something different, andropause is something different. Andropause is low testosterone in the male, low estrogen in the female is menopause. But both of these things usually happen in the same age groups, usually. So a woman having menopause, the man also in synchronous with him will be having the symptoms of andropause. So this is called couple pause. This is a new paradigm, but you need not know it because most of the people that come to the gynecologist for a sexual dysfunction are younger age group people only. Now we come in unconsummated marriage is the one of the common sexual problem that comes to the clinic of the gynecologist. It is defined as inability to be successfully involved in a sexual intercourse at the beginning of marriage, particularly in the first few nights. Unconsummated marriage. It can be 1 day duration or how much duration, that is incidence of unconsummated marriage. In the first night, 25% of the men fail to penetrate. In the first episode of sex in the first night, if they try next time in the same night, 10% failure. In the first 3 nights, 5% of the people may fail to consummate their marriage. In the first month, 2%. This is not an absolute figure. This is the figure which I have seen in my practice. So the caregiver is physician, gynecologist, urologist, psychologist, and sexologist. And a previous sexual experience of the man may or may not correlate with the unconsummated marriage. Then what are the causes for the unconsummated marriage when the couples come to you? In the woman, voluntary postponement is one of the reasons for unconsummated marriage today. As a procedure for not having children, fear or aversion towards sex, fear of pain at sex. Here we see fear or aversion to sex. Then to sex itself, here fear or pain at sex. Then really superficial pain, vulvodynia, a tough hymen, rarely, vaginismus, and anatomical defects in the woman are rarity. So these are in the order of importance. One. The last one is this one. In men, it is a subnormal intelligence, good number of instances, a personality disorder of the man, a psychiatric disorder in the man, a sexual perversion in the man, a sexual orientation, asexuality, bisexuality, or homosexuality. And the commonest cause of unconsummated marriage in a long term is he is ejaculating before entry, severe degree of premature ejaculation, and erectile dysfunction. These are the causes in the part of the male. So here to tell, in a case of unconsummated marriage or honeymoon impotence is one of the common things that comes to the practice for a gynecologist, whether it's a male gynecologist or a female gynecologist. It is quite common. So here, if you analyze all of the cases, honeymoon, this is rough figures of mine, my own. 25% are organic disease, whereas 75% psychological. In the psychological, performance anxiety accounts for 80%, whereas depression preceding that one. So performance anxiety about his own performance is the commonest reason for honeymoon impotence. Whereas in the woman, vaginismus, premature ejaculation on the part of the man, and endocrine and vascular disease in the man, undetermined. 1/4, 1/4, 1/4. So total put together, out of unconsummated marriages, only out of 1/4, 1/4, that is not more than 6 to 7% of the people, the reason is vaginismus. In all others, the male or the anxiety on the part of the man or ignorance on the part of the man is the reason. Now, these are my own findings of 100 cases. So this I skip because of the shortage of time. Now we go for the sexual dysfunctions leading infertility. Sexual dysfunctions and infertility as comorbid conditions. Infertility leading to sexual dysfunctions. Sexual dysfunction leading to infertility. Infertility and sexual dysfunctions coming together. Infertility causing sexual dysfunctions. Infertility causing sexual dysfunctions, that is different. Three aspects we are seeing now. That is sexual dysfunctions causing infertility. Erectile dysfunction is the one cause of infertility. Premature ejaculation anteporta. Suppose somebody is ejaculating before entry, or delayed ejaculation, or anejaculation, or retrograde ejaculation, or desire disorders in the man. He is not having a disorder. He is not having a desire. Then vaginismus. Along with these ones, homosexuality is also one of the reasons. Vaginismus in the woman, unconsummated marriage, and lastly, and you will be surprised, sex frequency is one of the reasons. Sex frequency, less sex frequency is so common today. Even though they are having a capability, they don't do it. So sex has become a lesser important to young men and women. So less sex frequency is causing infertility. You know, everybody, sex frequency only in the during the period of during ovulation period, then sex frequency during non-ovulatory period. So every alternate day anybody has to do. But most of the people are doing, I deal with so many software employees, they are doing weekend sex only, Saturday, Sunday, not in other days. Then the fertility potential becomes 1/4 lesser, only 1/4 of the normal, because the semen is not given in the proper day at times. So sexual dysfunctions and infertility as comorbid conditions. Endometriosis, it causes sexual pain in the woman and at the same time infertility. Same way PID, same way sexually transmitted infections. Hyperprolactemia causes low sex desire, at the same time causes anovulation. Then hyperprolactemia, hypothyroidism, and prolapse of the uterus, it causes sexual dysfunction, lax vagina, no erection in the man, and no satisfaction for the woman, and no orgasm. Then prolapse also can produce infertility. Or psychogenic diseases and the treatments for the psychogenic diseases. Now, this is for female. In the male, a phimosis can cause sexual dysfunction. A phimosis can cause infertility also. A severe degree of varicocele, making the testosterone lesser, can cause infertility, can cause sexual problem also because of low testosterone. Sexually transmitted diseases can cause both infertility and sexual dysfunction. Endocrinological diseases causes less amount of semen quality and semen quantity and erectile dysfunction. Whereas the psychiatric disease and psychogenic sexual and the treatments for the psychiatric, all of these diseases cause sexual dysfunctions as well as infertility. Now we go for the reverse. Infertility by itself causing sexual dysfunctions in the men. That is, in the men, sexual dysfunction in the men, less desire is so common in the people who are getting a treatment for infertility. Avoiding sex in the safe period. They need not avoid sex in the safe period, but they avoid. Only they do over ovulation day only. And 1/4 of the people who are in a treatment for infertility, they fail to have erection in the ovulation days. In other days, they are able to do it. It is only situational pressure. That is, during ovulation day, he is not doing sex. He is doing a job. The wages for the job is fertility. So He is doing a job, there is a failure. That means he is not interested to do, but he is forced to do. And the woman will be crying or scolding him if he is not able to do. That is the reason 1/4 of the people who are in a treatment for infertility with timed intercourse, they are going to have infertility, they are going to have erectile dysfunction. Only situational during that time only. It can lead to an ejaculation also. Infertility can lead to an ejaculation the man because he is not interested. It is a job. He is not excited here. His excitement, he is making excitement down below, but he is not excited here. When there is no excitement, there is no ejaculation. Now, erectile dysfunction, infertility. 11% of the men in the younger age group less than 40 will be having ED. 2% in 2% of infertility cases, ED is there is ED. So when they are having ED, they visit a doctor, they treat. If it is failed, then they won't come for infertility. If there is erection failure, not treatable, they get divorced. If at all there is success, then they come for infertility treatment also. So in infertility clinics, even though 2% are having a failure to do sex, only 0.5% of the people, the reason for infertility is erectile dysfunction, not the temporary erectile dysfunction of timed intercourse. Erectile dysfunction in general, only 0.5%. Now, studies on ED after infertility. Now, suppose somebody is not having erectile dysfunction before the infertility treatments or before the infertility. After treatment for infertility or after infertility maneuvers, mild ED will be there in 18%, moderate ED in 4%. Suppose somebody is not having ED at baseline, but at least moderate ED will be there in 4% of general population, whereas at timed intercourse, 25% will fail. If not the whole of the, suppose in timed intercourse they are doing 4 times sex, at least once he will be having a failure. Now, suppose somebody is already having ED, no ED at ovulation days, new ED at ovulation days is 24%. New ED at pleasure days is also there. This is ED with infertility. Now, female sexual dysfunctions after treatment for infertility or after diagnosis for infertility, that 58% will have pain. Desire will be lesser in 25%, orgasm will be lesser in 14%. Total 70% of women who are on treatment for infertility will be having one sexual dysfunction or other. In normal population also 40% will be having, but when they are on a treatment, 70% will be having one or other sexual dysfunction, because it is always a psychological, but it is always also iatrogenic also. The total number, so many investigations are done, so many interventions are done, so many injections are given, so many progesterone is given, hormonal interventions are done, whereas candidiasis is so common in treatment in people having treatment for infertility. All of these things are the causes for female sexual dysfunctions after infertility. Now, what is the treatment for ED in infertility? Only that much I am telling, not other things. The treatment is counsel the patient that you are doing a job, not you are not doing a sex. That is the reason. So do whatever you wanted to do. Don't see for the ovulation days. So for this one, we are the causative factors. Even though somebody is capable of doing sex on every day or every alternate day, there is no point in telling those people that you do sex on ovulation days, but people will tell the same way. So now Viagra was so temporarily on the day when he is not able to have good erection, ask him to take a Viagra tablet and anxiolytic. Then everybody will be inquiring, the patient will be inquiring whether Viagra is going to cause my sex problem, or when I am having a problem, when they are having a treatment for sex problem with Viagra, is it going to affect my fertility? No, the effect of Viagra over semen quality in IUI is there is a slight increase in the volume, there is an increase in the progressive sperm motility, there is an increase in sperm penetration test also. In fact, it is beneficial, whereas useful in premature ejaculation, delayed ejaculation also. Even delayed ejaculation, if you give sildenafil, it works. Now, if you are having a time, it is already 8:30, sir. So I discontinue teaching the what the wife responds, how the wife responds to erectile dysfunction of a woman. So it takes 10 minutes time because the time is up. I have taken more 20 minutes more than given to me. So I
We
close
have
it.
to take question answer session also. No?
Yes,
So,
sir. That is the reason, sir. So
yeah.
now I am stopping sharing. Yes, sir.
Yeah. So thank you, sir. It was a very elaborate discussion about the erectile dysfunction. I have a few questions, sir.
Yes, sir.
What is your experience regarding extracorporeal shockwave therapy?
Extracorporeal shockwave therapy
Hmm.
is not a treatment schedule accepted by all over the world.
Okay.
People use it basing on the inputs from the manufacturers, not from the inputs from the patients.
Okay.
So, in fact, the extracorporeal shockwave therapy, personally, I say, is a useless thing.
Okay.
It can improve a little, particularly in old age people, not young people who got damage in the. So, extracorporeal shockwave therapy is not till now accepted as a treatment for erectile dysfunction. It is only marketing gimmick. Personally, I feel people can use it, no problem.
Yeah. We want to know your experience or your opinion about it because same thing about stem cell therapy, sir.
So stem cell therapy and PRP also don't have any role till now. It is not a proven value. Except in orthopedics, PRP is not confirmed. In gynecology, it is confirmed, but not everybody accepting. But in a case of erectile dysfunction, PRP I don't think has any role because you will be giving PRP only for a damaged cell. That will be happening in the elderly age group people. In elderly age group people, why to give PRP? All of these things you can as well give a treatment. So it's not a solution for it. Personally, I say it is not of much use.
Yeah. Sir, many times patients have taken self PDFI inhibitor and they come to you and they say, okay, we have already taken this tablet. So how will you counsel and how will you manage such type of patient? Because now it is there freely available in any medical store.
Yes,
so
anyway.
Most of the patients take that and they come
on
after
their own.
taking it.
Yes, on their own they take. The cause that there is a specific schedule for it. This is failed cases, failure of or non-responsive to sildenafil. So non-responder to sildenafil is a separate topic. In this one, we are missing the first one. We are not treating the medical disease causing the sexual dysfunction. The first one. Suppose somebody is diabetic. Without treating diabetes, there is no point in giving sildenafil. So the first thing is that one. The second one is we are not treating. Suppose somebody is having testosterone deficiency, he may not. Somebody is having so much of anxiety, he may not. So for all these patients, a real that is the usage is not proper. Somebody has taken a Viagra and in 5 minutes he is expecting. The expectation is more. It takes a 1 hour. He don't wait for 1 hour. The next one he don't take before food. He takes after food. With a fatty meal he takes. With so much amount of 4 pecks he takes. So these are it is non-responder because they are not using it properly. The medical diseases are not treated. So for all of these things, that is re-counsel the patient how to use it, when to use it, what to use it, what time you have to give for the drug to act. The next one is, suppose somebody is not responding to sildenafil, he may respond to tadalafil. Very simple. May. Okay. So the other way around is, suppose somebody uses sildenafil, it is not responding. So personally I say, I give tadalafil tablet, low dose 5 milligram continuously, even though they not SOS, continuous dosage, continuously for 2 months. In addition, on the day when he wanted to do sex, he can add his own sildenafil. This works nicely. That is, we are priming the tissue with less amount of dose. It is just like we are warming the penis with tadalafil, and at the proper time, we are burning the penis with sildenafil. So these techniques, if somebody uses, most of the people will be relieved, particularly young people. If old people, if there is nothing, then we can't do anything.
Yes. Thank you, sir. And sir, next question is same. How do you decide which PD5 inhibitor to give to any particular patient? How you decide that?
Yes, sir. That decides a
No,
little mischievous
shall we take
words has to
questions?
be used. No, that is to which patient to give what sort of PDF inhibitor. So this is a quite interesting topic.
Okay.
That I teach a separate section. Suppose an unmarried boy is there. His necessity is he is having psychogenic erectile dysfunction only. So then you give an anxiolytic along with a sildenafil tablet, because he will be staying with her only for 3 hours. Sildenafil. Suppose he is going on a weekend with his girlfriend, then give him tadalafil tablet. It works for 2 days. Or the girl, he wanted to have the effect faster, then give evanafil tablet. Then he wanted to have not to be seen as taking from some tablet. So even though he is staying with her for 2 hours, we ask them to take a tablet before he starts from his house, 2 to 3 hours before he meets his girlfriend. Take a tadalafil tablet. It works whole of the day. So to be discreet, I ask those people to take a film to be kept over the one, just like a mouth freshener. Just like a mouth freshener, he uses it. Papers are there. That is, S-film is the trade name. This is for an unmarried boy. So somebody in the newly married life, his sex frequency is daily. Then you can't give sildenafil daily. Instead, you give 20 milligrams of tadalafil on alternate days at bedtime. That works for whole of the day, whole of the night also. Those people will do sex in the daytime also. That is the next one. Suppose an elderly man is there. His sex necessity is only once in a week. There is no point in treating with tadalafil. For him to treat only sildenafil. Suppose the same elderly man is having a affair with somebody and the girl wanted it on her desired time. Suppose when you wanted to use sildenafil, you should be deciding factor when to do.
Yeah.
But suppose in good number of instances, the girl will be the deciding factor.
Yeah.
She comes all of a sudden. Then I ask those people to take an evanafil tablet, go on doing foreplay. In 20 minutes, it starts working. That is ideal. In an elderly man who wanted to do sex only once in a week, use sildenafil SOS 100 milligrams. SOS. In an elderly man with a loss of blood flow, with a nerve strength, then tadalafil tablet low dose long term along with sildenafil SOS. This is practical solutions. I don't say this is solution for everybody. Practical solutions depending upon the new situation is there. Yes, sir.
And one more thing, sir. You said that in all ED cases, it is not necessary to check for the cardiac status unless it is only vasculogenic, right?
Yes, sir.
So
No,
how
sir.
you decide?
No. Yes, sir. Yes, sir. I'll answer it. Yes, sir.
So how you decide it is a vasculogenic cause of ED? Or
no, that is vasculogenic ED is the diagnosis is made by means of erectile dysfunction is there. When there is no other factor, because we rule out everything. There is no diabetes. There is no B12 deficiency. There is no thyroid. Testosterone is normal. Testosterone is also normal. Then that is, there is no disease accountable for the erection failure. Then we have to think that it may be, I don't say it is, it may be vasculogenic. It may be, but the treatment is same. The treatment for every erectile dysfunction is vasculogenic treatment only. because sildenafil or PDFI inhibitors work over vasculogenic only, whatever may be the treatment. So we go by that criteria. Suppose then you are asking a question, how to, there is no need of investigating vasculogenic, sir.
Yeah, that's
So the reverse you are talking. ED patient can have coronary artery disease. So when somebody is having ED, which may be of vasculogenic origin, just like in diabetes or peripheral vascular disease, then you have to investigate that patient for coronary artery disease, not for ED. For ED, vasculogenic ED has to be tested by means of only office sildenafil test, or much more nicely, penyl Doppler with pepaverine injection or alprazolam injection. That is, echo will be done by giving intracavernous injection of alprazolam, around 10 milligrams can be given. Then arterial blood flow you will be able to see, PSV, and end diastolic velocity you will be able to see. Then restive index you will be able to see. Only with that test you can differentiate between vascular and non-vascular. But blind rules are, if somebody is having nocturnal penyl pubescence, it is not vascular. Blind rule. I don't say it is perfect. Blind rule is, somebody is having nocturnal penyl pubescence. What does it mean? He is having blood flow. If somebody is capable of doing masturbation without any aid, somebody is able to do masturbation, that means by and large it is not vasculogenic. By and large, most of will be psychogenic. So it is by suspicion only. Confirmation of vasculogenic is so difficult only by means of a penyl Doppler with pepaverine injections. So it is technically difficult. So for every case I don't do. So because I see failed cases only, I do in most of the instances I do with penyl Dopplers.
okay, sir.
Sir, one more question, sir. Like you told, infertile people, for testosterone, if it reduces, we cannot give testosterone therapy because of reduced spermatogenesis. So that time,
Yes,
like
sir.
how we'll use SCG injection and how much we have given, like how much we should give and how long we should give, sir.
That is testosterone supplementation is forbidden in a man who wanted to have his fertility, because it reduces FSH, and FSH reduces sperm quality and sperm quantity or spermatogenesis. So in such instances, when the testosterone is less, the treatment schedule is, then look for FSH, look for LH, look for prolactin, look for estradiol. If the LH is more, LH range will be there. If at all it is more than half, then you cannot give, that is, suppose the range for LH is this much, suppose 2 to 14, imagine, or 2 to 9. The range of LH in a man is 2 to 9, imagine. Then if at all it is less than 2, definitely it is hypogonadotrophic hypogonadism. Correct? Less LH, less testosterone. Hypogonadotrophic hypogonadism. In these cases, HCG has to be given. Suppose there is FSH is also less, then you have to give FSH. The schedule, how much to give? 5,000 international units 2 to 3 times a week, continuously for 2 to 3 months. Then assess the testosterone after 2 to 3 months. Then FSH has to begin 150 international units once in a week for 2 to 3 months. Usually we give. Then we see for the spermatogenesis after 2 to 3 months. Now we come to the next one. But it is a costly affair. How many number of days anybody can afford? But the next one is, in which case of low testosterone and sperm problem is there. Low testosterone makes the volume of the semen lesser. Normally, just to tell in a blind words, low testosterone produces low volume semen. testosterone acts over the seminal vesicle to produce the fluid of seminal plasma. So when the testosterone is lesser, the volume of the semen is lesser always. So when the semen, that is, when the testosterone less and LH is more, FSH more, then it implies that that primary testicular failure, hypergonadotrophic hypogonadism. In such cases, you can't give FSH, you can't give FH. So what to do? So the treatment is, you give clomiphene citrate 25 milligram daily. It may, I don't say it is, it may suppress the FSH, may increase the spermatogenesis, may suppress the LH, can make the testosterone more. This is the practical guide for semen quality versus testosterone deficiency.
So one question.
Citrate, how many months we can give?
Yes.
Clomiphene citrate, how many months we can give to this
Any
person,
number
sir?
of months, 3 to 6 months minimum.
And sir, how frequently we should repeat this testosterone and FHS LH level, sir?
No need of that is after 2 months only, 2 to 3 months, because the cycle of spermatogenesis is 2 to 3 months. So there is no point in estimating testosterone or FSH continuously every month. That is the commonly done by every infertility institute will do. Every month they go on seeing semen analysis, every month they go on doing FSH LH. It is a business proposition, but theoretically, once in every 2 to 3 months only you can repeat FSH and LH and then testosterone values and semen values, not every month.
And sir, this testosterone therapy, if we'll give, then how frequently we have to see an investigation, sir, like repeat testosterone
Suppose somebody
therapy?
don't want it, somebody is having low testosterone. So I just now I told you there, somebody not having a desire, that is 450 nanograms per deciliter. Somebody not having that strongness of that mind or masculinity, we call it, then 360. If somebody is not having, less than 240 nanograms per deciliter, then it leads to ED. So for all cases of ED, you need not give. Even if it is less than 240, he is not having a problem, you need not give. If he is having an ED, then you have to supplement testosterone. Supplement testosterone is by means of one of these things. The commonest thing you do is 250 milligrams once in 2 to 3 weeks. Go on giving it for 2 months or 3 months. Then afterwards, 1000 milligrams once in 3 months. So after every year, usually after every year, because it is a long-term treatment, somebody having low testosterone, there will be some reason. For some people, it is a lifelong treatment, just like thyroid. It is a lifelong treatment. So every year, you ask the man to get hemogram done to rule out erythropoiesis increase. The second one, you ask those people to do PSA, prostate-specific antigen. You ask them to get a testosterone estimation to be done every year. Depending upon that one, for the next year, practically I do. So if you give a little more time, so testosterone supplementation for an ED or anybody else, not for infertility. Once they complete their family function, family fertility potential, then we have to. That is, I give testosterone 250 milligrams once in 2 to 3 months for 2 to 3 doses. Because once you inject, you don't have a control over the testosterone value for the next 2 to 3 weeks. Suppose it is causing so many pimples, you can't. That is, the side effect is not in your hands. You can't withdraw a drug which you have given already, because it's going to work for 2 to 3 weeks. Suppose you give long acting once in every 3 months. In 3 months, you are helpless. You can't eliminate the drug from inside. So practically, I give for the first 2 months, once in every 2 to 3 weeks, followed by, if at all he is tolerating testosterone nicely, then I ask him to take one injection every 3 months. any number of years. But you have to be cautious. Yes, Tamma.
Last question, sir. FHS, LH, and testosterone at particular timing, like what timing we should advise them to invest, do this FHS, LH, and testosterone, sir?
In a male, not in a female, I am talking. In a male, testosterone has to be estimated. Testosterone estimation is so variable. It is usually more before 10 a.m. After 11 a.m., the value will be lesser by about 15 to 20% in the evening. So you have to estimate testosterone, total testosterone, on 2 separate occasions 1 week apart before 10 a.m. If both of these things it is lesser, then only you have to brand that as low testosterone. Otherwise, you are not permitted. Suppose the next step is, suppose somebody is having ED with a normal testosterone and you suspect that he is having testosterone deficiency, then you have to go for free testosterone values also. The free testosterone values are more reliable than total testosterone values. The free testosterone value by estimation, in normal estimation, is technically difficult and the results are vague. So there is something called calculated free testosterone by means of albumin, SHBG, total testosterone. A calculation is made to make it free testosterone. Free testosterone estimation is more valuable than total testosterone. But because of the cost, because of the technicality, people won't do it. So it has to be done before 10 a.m.
Sir, according to you, any role of Kegels exercise or yoga in such group of patient with ED?
So with ED, exercise, physical exercise in fresh air, I don't think that for ED, personally, I don't think in ED, the role of meditation, the role of yoga, it is another form of physical exercise. Personally, I tell, in which way yoga, yogic exercise only people do. Yes, sir, practically to tell. I am not a yogi therapist. And practically, what people do is yogic exercises only, yogic physical exercises. Nobody will concentrate on the other chapter of yoga, that is how to apply your mind to the technique which you are doing. So it works as physical exercise only. But the real thing, the benefit will be there only if you apply along with the mind. So all that is, yoga is different, yogic exercises are different. What people propagate in the name of yoga is only yogic exercises. It is not more than a physical exercise. But there are some techniques which people claim that it is similar to Kegels exercises. Similar to, or pumping is more, but nobody is sure of it. So here they claim that they are having more amount of more relief will be there, more result is there. But is the result because of the willpower of the man who is doing yoga, willpower, or because of the exercise itself? I personally feel it is the willpower of the man to do yoga. Then even if you don't do yoga, even if he does exercise just like patting his head, that may be working, because it is the willpower of the man that is going to count. That is the psychological aspect of yoga. And the willpower of the man to cure himself, that is going to give more result than yoga. So somebody who is doing yoga, everybody thinks that is the effect of yoga. Is it so? Don't know. So it is just like RCT trials.
So how often you recommend the testosterone prolactin evaluation in routine ED consultation?
Routine ED consultation, there is no need of prolactin for everybody unless there is an indication. For routinely, for every ED case won't mean somebody having a erection when he met a girlfriend. No, ED is for a long term. Long term. Suppose somebody comes, practically I see only long term cases only. They don't come directly to me. Most of my is referrals. Even if direct case comes, I do blood sugar, number one, cholesterol, and testosterone. Only these, nothing more than that I do. Prolactin also usually I don't do. And suppose, but patients insist upon getting every test done. Then we are forced to do so many tests. They don't be satisfied unless you don't do. If you don't do, then they think you don't know. So the indication is not ours. The indication is patients. It is not, we are not cheating. They are making us cheat. They are making us to cheat them.
Sir, do you do routinely penile Doppler or in particular cases only for?
No, not a penile Doppler is not a routine thing. Penile Doppler with vasoactive drug is not a routine thing. Routine thing because it is technically difficult and there are very few people who do it correctly. Very few radiologists are comfortable in doing penile Doppler. And really, priapism is one of the complications of it if you do with papaverine. Suppose if you send 100 people, at least 2 people are going to have priapism. Then it is such a headache for you. So instead, I ask those people on an indication only. On an indication only. When I say sildenafil is not working, PDF inhibitors are not working, then I ask those people for elderly men, I go for penile Doppler. But I told you I see good number of failure cases only referred by other sexologists or urologists. Then I get half of the cases which I receive as AD. They are long standing by definition only. Most of the cases that ordinary doctors will see, a general practitioner or a specialist also, most of the cases are psychogenic. Only 25% are organogenic. In that one, 1/4 only vascular. So total put together, so in all cases of elderly people having diabetes who are not responding to sildenafil, I get a penile Doppler done. In all cases, elderly people, and particularly in young people who are not able to do with any amount of drugging, any amount of psychotherapy, then thinking that there is some congenital abnormality in the vasculature of the penile of the cavernosal veins. Just like suppose somebody is having varicose veins, or somebody is having a varicocele, that means the veins are not having enough of strength. The same thing if it is happening in cavernosal veins, it results in leakage of blood. So anybody who is having this sort of thing, this is only out of experience, they are not given in the textbook. Out of experience we see, yes. By common sense only I am telling. Suppose somebody is having a varicocele, what does it mean? That means there is a vascular defect. So then I ask those people, suppose he is not having erection, he is not having erections, then I ask them to get it. In fact, 1/4 of people who are having varicose veins of the legs, definitely there will be venous incompetence. So that is the final test of venous incompetence. Nothing works. If there is a venous incompetence, nothing works. If it is an arterial disease, sildenafil works. If it is a venous incompetence, no drug works. You have to go for penile Doppler, penile implant only. So in that cases, for decision, we get a thing done.
Is there any question?
Question from Mr. Jahan.
Is there any question in chat box from our delegates?
Yes, sir. Question from Mr. Jahan. He's asking, how do you differentiate psychogenic and organic ED?
Yeah, that was in slide. Yeah.
It is there. I have given in slide.
Yes.
Yes, sir. So another question. Post prostatectomy patients, what penile rehabilitation have shown the best outcomes?
Yes, sir. Because this is not for gynecology. So this is for gynecologist only. And penile rehabilitation is to be done for every man who has undergone prostatectomy, not for simple TURP, but people who underwent cancer surgery, even though nerve-sparing cancer surgery for a prostate. Definitely the blood supply is gone. Even though nerve sparing is done, some amount of nerve supply is gone. So that results in number 1, retrograde ejaculation. Number 2, the blood flow to the penis will be lesser. The nerve supply to the penis will be lesser. When the blood flow to the penis is lesser, then the penis shrinks. Suppose nothing is done for a prostatic cancer surgery man, the size of his penis becomes lesser by 1 centimeter after 6 months in a flaccid state. So they may not be using the penis at all, but still they wanted it to be longer. This is quite common in elderly men. So penile rehabilitation is done to restore the penile length, number 1, to increase the penile blood flow. So for every case of prostatic cancer surgery, 2.5 to 5 milligrams of tadalafil is to be given starting about a week after surgery, continuously, anywhere up to 6 months to 2 years. Or a penile rehabilitation that prevents shrinking of the penis. I told you, even though he is not using it 70 years of age, prostatic cancer man, he may not be using it ever, but still he wanted his penis to be longer. There is a common sense. So we always give. The next, another alternative, if he is not fit to use a sildenafil or tadalafil, then what to do? Vacuum machine can be given twice a week for 15 minutes so that it sucks blood into the penis. We need blood flow into the penis. But that works only if at all the penile rehabilitation is instituted at the earliest, usually after a week. So penile rehabilitation for a prostatic surgery. The same thing holds good for any patient who underwent cancer surgery for colon, or a pelvic excentation surgeries, or a surgery over the bladder for a man. So all the nerves get cut. So for all these patients, a penile rehabilitation can be done the same way.
So one more question. How is the effect of these tablets, which are finasteride tablets, used for this hair transplantation, local and oral? How is the difference?
So finasteride tablet is always taken orally. It is taken in a dose of 1 milligram. Almost always is taken orally. 1 milligram to 1 milligram is taken for hair transplantation or for hair growth. 1 milligram is given continuously. It takes a little more 2 minutes to extra time, sir, to explain this one. So 1 milligram tablet is given for 2 to 3 months to 6 months, finasteride tablet.
Yes, sir.
And finasteride tablet, normally testosterone is converted into dihydrotestosterone. Dihydrotestosterone is active ingredient, active metabolite. Dihydrotestosterone is 10 times more potent than testosterone itself. So dutasteride prevents the conversion of testosterone. Finasteride or dutasteride prevents conversion of testosterone into dihydrotestosterone. So even though the testosterone is more in amount, it is not being utilized. So that is the reason for option. That is the reason for hair growth, isn't it? That is the reason for hair growth. Hair fall is because of testosterone. Hair growth is less testosterone. So dihydrotestosterone is for secondary sexual characters. Testosterone is for erection failure. But suppose a man is using 5 milligrams of finasteride continuously, then also not more than 2% of the people will be having erectile dysfunction. Okay. Even though he is using 5 milligrams of finasteride continuously for about 2 to 3 months, not more than 5% of the people will be having erectile dysfunction. But there is another hitch that is called nocebo effect. Normally we know placebo effect. Nocebo effect is negative. Suppose somebody is informed that finasteride can cause erectile dysfunction in you or testosterone deficiency in you, those people are going to have definitely erectile dysfunction. So the nocebo effect is far more powerful. So if not informed people, not more than 2 to 3% or 5%, but definitely people who are informed by you or by your assistant or by the
Google.
Google.
AI, definitely they are going to use it. And dutasteride is far worse than finasteride, sir. Dutasteride is 10 times more worse than in erectile failure. Yes, sir.
As a local with minoxidil, they are using, the dermatologists are using with local finasteride plus minoxidil.
I don't know, sir. Because the dose, I don't know. How much amount it is going in, I don't know.
We
I
don't, we
don't
don't know.
know.
Yes.
Because the local, how much it is going inside, we can tell when it is taken orally, how much.
We can
And
tell.
how much it is applying, what is the concentration of the finasteride, we don't know it.
Yes. Yes.
So when we don't know, there is no point in answering.
Yes, sir. So one more question from Mr. Samir. He's having question: if the infertility patient, if the testosterone is less, then how much HCG should be given and for how long?
Just now I
That sir, I
answered.
already answered. Yeah.
Answered
Already answered.
already.
Yes. Yes, sir. And then one of the question was, if he is worried about the penile girth, how should we treat that patient and counsel him?
Penile girth. Yes, sir. Penile girth, there is nothing to improve. There are new techniques are there. Some people are giving hyaluronic acid. Some people are giving fat infiltration into the subcutaneous tissue. Some people are giving PRP also. All of these things are of no use. They are not of proven value. There is no drug to make your penis thicker. Then how to counsel that patient? Very simple. That is being a gynecologist also. Then I advise those people. At delivery, the baby's head comes through. The baby's head is this much size. It is accommodating. That means it is such a bigger, having bigger stretchable capacity and regaining that tension soon. So it is the amount of the strength which you are having, not the length, not the girth, that counts. So because vagina is such a stretchable organ, you need not bother about. If you insert one finger into a vagina, it fits. If you insert two fingers, it fits. If you insert a fetal head also, it fits. So there is no point in increasing the girth of the penis. In fact, most of the people who think that the girth of the penis is becoming lesser, or the length of the penis is becoming lesser, is not because of that one. He may be having mild grade ED also. Suppose, just a little extra I am telling you. Suppose somebody comes with, earlier my penis is longer, sir. Now it has become lesser in size. Then I give an example. There is a balloon which is 6 inches long. If you blow it fully, it becomes 12 inches long. If you can't blow it fully, it becomes 9 inches long only. That means the balloon is shorter or your blowing capacity is lesser. That means your pumping capacity is lesser. It is seen as less length of the penis. That is the answer which I give. This is it looks funny.
Yes, sir.
This is an analogy we should show to the people because psychotherapy is such a difficult job.
So one more question that is not very relevant from Swati. She's asking branded or generic semaglutide, which one is better? That is not our actually.
Yes. I say always branded, costly is always better. It is going to work over the mind also.
Yes, sir.
Very simple. There are people who insist upon, it is just like asking people, a Gudumba or a country liquor is going to give you more kick or a Scotch whiskey. I give such an example. It depends
Yes,
upon
sir.
you.
Yes, sir.
The answer is that one. In fact, I
So
say
last question from me. Mr.
Yes, sir.
Harris is asking a very common question. Is masturbation causes ED?
Masturbation causes ED if he feels that it is causing ED, going to cause ED. Masturbation is not going to cause, but it is causing ED. Reverse also I am telling, masturbation won't cause ED physically. If he feels that masturbation is going to cause ED, then definitely he is going to have ED. But the real one, which I told you, my thesis topic for my PhD is Pornography-induced erectile
Pornography,
dysfunction.
yeah.
People who are accustomed to do masturbation with pornography. Without pornography, they can't have erections because they are dependent on pornography. They are not addicted on pornography. They are dependent on pornography. So these people cannot believe the same thing. These people cannot believe that pornography, that masturbation is going to produce masturbation, which is dependent on pornography. The second one, your question is right. I told you wrong, but it is right also. Suppose somebody is doing masturbation in the classical technique of to and fro movement, graduation from this masturbation to coital movement, thrusting, is so easy. There are a good number of the people who always do masturbation by rubbing against the bed. So the mind cannot change so easily to this sort of movement. They are moving like this, or some people will simply press it. Some people will press it against the one, the pressing itself. So it is the abnormal masturbatory techniques. To and fro movement can graduate from masturbation to penetrative sex. But people who are having different masturbatory techniques, some people can have erection failures, and some people can have delayed ejaculation or anejaculation also.
Sir, one more question.
Their masturbation technique will be different.
Yes,
so
got it.
they cannot have ejaculation. So there are cases.
Masturbation technique which is synonymous or equivalent to the natural penetration,
Yes,
that
sir.
will be normal.
Yes, to and fro movement of that is naturally
Yes.
they can graduate the technique into penetrative sex, but other techniques are difficult. So
Yes.
different style of masturbation, that is so difficult. The rare cases are there, different masturbate techniques who lead to unconsummated marriage, erection failure. Even though they enter, they can't maintain, because when they are habituated this way, suppose somebody is habituated to do masturbation with good strength of the penis, they squeeze their penis, they harm their penis. There, the penis will be, the vagina won't be having that much of good feel.
Yes.
So there are different masturbatory techniques. So altered, not normal masturbatory techniques. Classical masturbatory technique usually won't.
Okay.
Sir, any role of penile girth in ED, sir? Because
that
one of
already
No.
answered.
No, there is nothing.
because few patients, they are seeing pornography movies and they are like their penile growth is very
Yes,
low
that-
and they are not able to
That
Already
is-
answered that question.
That is
So
already
when you-
answered the question, that it is the misinformation that is causing misinformation by porno, now misinformation by short videos over social media.
Internet.
That is causing that.
Thank you,
So
sir.
one more question, management of venogenic ED from Samir.
Management of,
Venogenic.
yes, management of venogenic ED, there is no medical treatment for vascular or venogenic ED. That is to be decided by means of penile Doppler with a papaver injection with full dose. Suppose there is diastolic pressure, just like we see in a case of fetal Doppler, loss of diastolic flow. It has to be negative. Suppose it is persistently in diastolic velocity, EDV we call it anywhere. EDV, if it is persistently more than 5, throughout the technical procedure of 30 minutes, if it is more than 5, then it is definitely a venogenic. There is no medical treatment for venogenic erectile dysfunction. Only penile implant is the solution. Earlier, people used to tie the knots over the veins, just like varicose veins. But much more easier solution. How many veins you can control? There are hundreds of veins that is penetrating the tunic albuginea. You can't do it. So instead, much more easier technique is, because once there is the cavernosal tissue, it goes dead because of anoxia.
Okay.
Because of anoxia, it goes dead. So instead, penile Doppler, this penile implant is the treatment.
Okay, sir. Thank you. So now I think it's time to vote of thanks, Naisargi. No more question, na, Gautam?
Yes, sir. No more questions from my end.
Okay.
Thank you, sir.
So no other questions in the chat box as well.
Yeah. Naisargi, unmute.
Yes. Thank you so much, sir, for this excellent talk and our all queries to solve the all queries. Thank you, Neeraj sir, Shama ma'am, Apurva Datta sir, Gautam sir for sharing this session, and thank you, audience. Without you, we cannot success this program. Thank you so much.
So I thank from my side for inviting me to give a talk second time also, because now earlier I was a gynecologist, I was a private practitioner, I was in government also, but afterwards discontinued practicing gynecology because of the heavy rush I used to see. Then I wanted non-emergency things only, which we can't. So after being in profession for 30 years, I discontinued and came to sex medicine. In sex medicine, I learned sex medicine in a systematic way. So now I see only sex medicine, but I teach gynecology. Just now you told. So that makes me, I can see from the woman's side. I can see from the woman's doctor's side. I can see from the male side. I can see from the male's doctor's side. That is the reason why I am able to answer you. Very simple answer. so
Thank you, sir. It's always pleasure to have you in our session. So we will, in future also, we will continue to do session with you. So
yes. So I was never involved with Foxy, sir. For the 15 years, I was not a member of. I'm not a member of Foxy till now. I'm not. So I never attend. So you are a very popular vice presidents of that societies, isn't it? Sexual
Yes.
Medicine Committee Society. So
Yes.
I don't know any of you, sir. Pardon me for not knowing any of you. I restrict myself to patients only. I was never in these organizations. Suppose if at all you wanted me to be there in one of your organizations of sexology related to gynecology doctors, I am very happy to be associated with. So nice.
Definitely, sir.
Thank you.
Definitely, sir.
Okay, sir.
Thank you, sir.
Thank you.
Good night, everyone.
So good night. So
Good night.
shall we leave? Yes, sir.
Thank you.
That means 8
Thank you,
people
sir.
are here and some people are listening. They're not here. So many people are listening. Yes, sir.
Yes, sir. People still want to listen you.
No. So many people are There are only 8 people are there online here. So
Yes,
that
sir.
means other people are listening. How?
Yes, sir. Sir, they are on the Mediset platform. They have their own platform. It
Yes,
is released on telecasted
So
on their.
it is
There will be
telecasted. They are
another
speaking
link
about
for
that one.
delegates, sir.
Yes, sir. Yes, sir. Yes, sir. I don't know that one. So I am thinking only 8 people are listening.
No,
There
these
are
are
good
all
number of
the
people.
No,
these are all
sir.
management people. These are
Yes,
from
sir.
the team, sir. Our management team, and other participants was not there
Yes,
in this
sir.
group. Yes,
Participants
sir.
will be having separate link.
Separate
There are
link.
good
Yes,
number
sir.
of
Yes, sir.
such people.
Yes.
Yes, sir.
Yes, sir.
Oh, sir. So pardon me for my ignorance.
I will let you know the number of viewers, sir, for
Yes, sir.
sure. After this webinar, I will send it to
Yes, sir.
Neeraj, sir,
Okay.
Yes,
for
sir.
sure.
Yes, madam. Okay. So shall we
Thank
leave?
you.
Yes, yes. Good night,
Okay,
sir.
sir. Thank you
Good
so
night,
much,
Okay.
sir.
everyone.
Good
Thank
night.
you,
Thank you.
sir.
Thank you. Good night,
Good
Neeraj
night,
sir.
sir.
Thank you for
Good night, Gautam.
inviting us. Thank you. Thank you.
Good night, sir.